Yeah, good morning, Professor Mary Shepherd, Dr.
Good
Rajesh,
morning. Very well.
Good morning, Dr. Sinan.
and good evening to all rest of my friends and colleagues and seniors here. It's a great occasion today that we amongst us we have Mary Shepherd, Professor Mary Shepherd, and she's a professor of cardiac pathology at St. George's, London, St. George's Medical University. And I was just going through the phenomenal work she has done, the kind of data she has got and the kind of data banks she has got, some 7,000 odd cases of sudden cardiac death. That is wonderful. So I was just talking to Dr. Rajesh, and we were discussing how to steer this program. We thought we'll invite stalwarts like Dr. Praveen Chandra, Professor Nakul Sinha, and our own director and HOD, Dr. Pramod Kumar, and rest of our friends, consultants who are working with us. See, sudden cardiac death is a big menace. And what we see, especially in our own country, that, every day we are watching television and we are seeing that some celebrity is going away. Sudden death, we were helpless, we could not save them. So this kind of scenario we are suffering from, and I'm sure about 10 lakhs per year would be the average number of cases of sudden cardiac death here in our country. Ma'am, you know that you are extraordinary in pathology. You are enlightening us in understanding the basics of sudden cardiac death, and especially you are focusing your talk on younger individuals. That is another issues, coronary anomalies, channelopathies, genetics, and all those things. So it's a great occasion. And I thank Dr. Rajesh, who is the director of Global Research Organization, Health Organization at London, who has really helped us in organizing this program. We know that sudden cardiac death is a big loss to the country, to the family, and it's very shocking if you see a patient who dies suddenly, especially the younger individuals. And one of my family members who were in Connaught Place, Delhi, suddenly a couple of years back fell down after dinner, and we could not do much despite the nearest hospital. And I was surprised that Children's Hospital, there was no shocking device, no AED, nothing like that, and we lost him. So this gives us a drive, and I'm sure Mary is going to give us newer and newer thoughts. With this, I switch over to Dr. Rajesh, who is the coordinator of this program, and for his vision and his thoughts. Thank you.
You are on mute.
Thank you so much, Dr. Sinha, for your kind introduction, and thank you to the Medanta family for organizing this talk. As Dr. Sinha mentioned, I am a cardiologist at St. George's, but I've got special interest in inherited heart disease because as part of my research, I used to do lots of inherited heart disease clinic along with Professor Mary Shepherd to see many of these families who die suddenly. In the UK, the incidence of sudden cardiac death is about 12 per week. So we see almost about 12 patients, 12 young individuals between the age of 14 and 35 dying suddenly in the UK. Unfortunately, I'm not 100% sure what is the incidence in India. And that is where I would like to speak to all my experts today in the panel to see what their thoughts are, what their vision is to how to deal with this problem. So again, not wasting too much time, I would like to introduce my expert speaker, Professor Mary Shepherd, who does not need any introduction in the world of cardiac pathology and pathology. She is the head of department at the St. George's University Hospital in London. She is also the president of the Royal Society of Medicine. Professor Mary Shepherd has done extensive work across UK and Europe in looking after sudden cardiac death family, giving them a diagnosis. She's got a huge database of several thousand of these patients. And we would love to learn from her because, again, this is where we think where the future lies ahead as far as sudden cardiac death in India is concerned. What needs to be done? What kind of database is required to give us some answers long term and prevent those sudden cardiac deaths happening in India. So thank you so much, Professor Shepherd, for taking out time on a weekend to speak to us. And over to you. So we'll like you to give your talk, and then obviously I'll bring in the other experts, chairpersons, for their vision and their talk about your talk after once you're finished. So thank you so much, and over to you, Professor Shepherd.
Right, I'll share my screen now with you. Yeah. Now, do you see that? You see my screen?
Not yet. Not yet.
You see me, yes? Oh, yes.
Yes.
Host disabled screen sharing. So will I now screen share?
We need to disable the screen share, Achal.
Yeah, he does. Is that okay? Is that done? Yeah. Yes, it's now. Can I screen share now?
Yes, Prof.
Yes, you've got it?
Has
it been
disabled? Has it been disabled, Achal?
Ma'am, we are giving you an access.
right? I can go back again to Zoom.
Ma'am, we
Yeah.
are giving you an access to share your screen.
Yes. Yeah. Share. Yes. Yeah. This is it, and hopefully now this will work.
Yes, Prof. We can see it. Absolutely.
You can see. Excellent. Thank you very much. Thank you for the introduction. I am honored to speak to you here today, mainly to cardiologists. You can hear me, yes?
Yes, ma'am.
Yes. And as already said, I'm based at St. George's Medical School, as Rajay said, where we've a special interest in sudden death and inherited cardiac disease. Now, what is a pathologist? Well, we do many things, particularly cancer diagnosis, as you know, with biopsies and resections of cancers. But we're involved in research and teaching, in hospital medicine and diagnosis. But I've down here the coroner, and that is a legal person in this country who's appointed in the area. We have about 80 of them who investigate sudden death in the community. So that is where the pathologist is heavily involved with autopsy work and the coroner. Now, as we know, the autopsy has a long history from Egyptian times through to the Renaissance and anatomy, and really all the advances that have been made in medicine have been through doing autopsies. Why do we die? Because it gives us an insight into diseases, old diseases and new diseases, and diseases like sudden cardiac death. So the role of the autopsy is still vital even in the 21st century. The big issue for us pathologists and cardiologists is the incidence of autopsies is going down. That people think that now we can diagnose things very well and we don't need autopsies, which is untrue when it comes to sudden cardiac death, because really the causes of sudden cardiac death cannot be shown by imaging. And the majority of people who die, as already mentioned, is they die suddenly. They've not been to a doctor before, or they've not been investigated by a cardiologist. So the skill in doing autopsies is reducing because pathologists do not do as many autopsies as we did 40, 50 years ago. While the autopsy rate is going down in incidence, the amount of imaging is going up. People thinking, well, we can put things and put a body into a scanner and that will show us the cause of death. Now, that may be useful when it's an intracerebral bleed or a ruptured aortic aneurysm or maybe diffuse tumor. But when it comes to sudden cardiac death, I'm afraid imaging is of no use whatsoever. It won't show you anything in the heart. Yes, with time, imaging may be useful, but the claims being made today are very limited. will expand in the future. So in other words, we don't use routinely imaging. It's used in trauma, road traffic accidents, cerebral bleeds, but not cardiac. Now, here is a recent survey throughout Europe showing you the autopsy rate. And you can see that in many countries like Russia, Turkey, Spain, Portugal, we've no idea of the autopsy rate. Very low in France. We've got a 17% autopsy rate in the United Kingdom, 18% in Austria, 40% in Hungary. Other countries variable. No results from Poland or Italy. So in other words, there's a variable autopsy reporting incidence. We really need to get more information. And that's why I welcome some information from India. I know where the autopsy rate is low as well. Now, we have guidelines as pathologists given out by the Royal College of Pathologists. This is guidelines on autopsy practice, sudden death with likely cardiac pathology. And this was done by Kim Suvarna and myself. In 2022, we updated it. And what this is that it emphasizes when sudden unexplained cardiac death occurs, close relatives are at potential risk of also having a fatal cardiac condition. A coroner's post-mortem is vital. More information about the coroner can be provided, and a standard which specifically looks for the commonest causes of premature sudden death has been drawn up. In other words, we look at the heart and we take as well appropriate material for subsequent DNA extraction. In other words, we do genetic testing. And what we normally take is a piece of fresh spleen at the autopsy. In addition, we have guidelines for sudden death updated from the Association of European Cardiovascular Pathology. These are my colleagues in Europe. And throughout Europe, we are now promoting the investigation of sudden death with autopsy and the taking of material for genetic analysis. Now, what is the coroner? As we said, we have over 500,000 deaths in England per year, and all sudden deaths are reported to the coroner, who's a legal representative. Here he is with his coroner's officers who help him, and 25% of all deaths in England have a post-mortem. So we've a high rate, 100,000 per year. We've 132 coroners districts throughout England. So the coroner, when someone dies suddenly, orders a pathologist to do the autopsy. And this is the incidence of autopsies, which is not going down, I'm glad to say, throughout the United Kingdom, with some areas having large rates, other areas having lesser autopsy rates. Now, as we're aware, there's a global threat to humanity. What is that? Through obesity, not so much bird flu or COVID, but from cigarette smoking and obesity. It's one of the big risk factors. Why? Because the majority of people who die suddenly, older people particularly, ischemic heart disease. It's still coronary artery disease that kills the majority of older people. So it is offering lifestyle treatment for hypercholesterolemia, lifestyle factors, obesity, etc., needs addressing. But when we did a study, and this was with my mentor, Mike Davis, in the 90s, we found ischemic heart disease with myocardial infarction here shown and thrombosis within the coronary artery as the major cause of death. But what I'm concentrating on today is young people dying. And as already mentioned by Rajay, 12 young people in our country die each week. And these are all who could be our children, our brothers, our sisters, our parents. And even as in 1632, you will see there that there was 68, or was it, yes, 62 sudden deaths. So even in 1632, we had people dying suddenly. And there has been recently a lot of actual media, social media, from young people, particularly like this young man who did a BBC program showing about sudden death, my sister's silent killer. His 16-year-old sister was found dead in bed at home, and the trauma that was inflicted on him and his family, and the fact of screening and the importance of screening for him and his parents. to deal with this trauma and also the potential of them having a cardiac condition. It is now being highlighted in the community through social media. It's also highlighted through the death of fit young people, like here footballers, famous footballers, rugby players, swimmers, football players, the cream of society, the prime of life, our supreme athletes who have died suddenly on the football pitch. So what is the incidence of sudden unexplained death in young adults? Well, our work with Michael Papadakis in 2009 in people under the age of 35 was 1.8 per 100,000 individuals. In Denmark, it is higher at 2.8 per 100,000. Here in Ireland, 2.9. And in Australia, where they had a large nationwide study, it was 1.3. So the minimal we have is 1.3 per 100,000 individuals. And due to sudden death in our country, a very inspirational woman called Alison Cox, who had suffered a bereavement and sudden death in her family, realized the importance of cardiac pathology and misdiagnosis. And she, with the help of coroners and politicians, actually funded the establishment of a laboratory that would process hearts that have suffered a sudden death with an autopsy. And with the establishment of this laboratory in 2008, what we did, we call it the CRY Center because the charity is called Cardiac Risk in the Young. We receive hearts from all over the country. We process the hearts and we actually do histology on the hearts. And we also take a piece of spleen for genetics. So we have staff, we have a laboratory, we have the facilities to examine these hearts. What we ask the pathologist to send is the whole heart, and in addition, a very small piece of fresh spleen that comes with the heart that can be fixed in a reagent that allows us to preserve DNA. This is important for genetic testing that will be of help in family screening. And this actually shows the number of hearts in red that we've received in the last 10 years. We've received an average of 500 hearts. And what the blue histogram shows is the number of material that we're getting genetic testing. Over half our cases now have genetic material coming in. In other words, the pathologists are sending us the spleen that is suitable for DNA extraction. So we can do molecular testing on over half our cases. So the message is getting through to pathologists, examine the heart and send the genetic material from the autopsy. Here is what we do. We take blocks of tissue from the heart muscle, we embed it, and we make paraffin blocks out of it, and we process it. Well, we get consent from the family. And what we tell the family is that the material we take is only the size of a coin. So the family, if they want the material to be looked after and buried with their beloved, the whole heart, most of it can be returned to the family with their wishes. We actually obey the wishes of the family for what we do with the heart and the genetic material after it has been taken at the autopsy. So we take a very small amount of material, but that allows us to make a diagnosis looking down the microscope. And also we have developed a database, and in this database, we record everything: the history, the circumstances of the death, the age, the sex, the body weight, the family history. Previous ECGs are actually scanned in, previous imaging if they've had that, heart weight, heart measurement. We will photograph the heart. We will do microscopic examination. We will issue a cause of death, and we will send letters out to the pathologist and to the coroner within 14 days of the heart being received in our department. We receive cases from all over the United Kingdom. And here is the average. We have now got, as said already, 7,000 cases in our database. And you can see the majority of people who die suddenly are in the 20 to 29, 30 to 34, and 35 to 39, up to 44 age group. The prime of life, this is when young people are dying. Yes, we get outliers, older people with genetic diseases, but the majority lie between 20 and 40 years of age. What is our exam? The actual role of the post-mortem is to do, obviously, eliminate non-cardiac causes like neurological causes like intracerebral bleeds, tumors, respiratory disease like COVID, pneumonia. Obviously, toxicology is important. In our country, 10% of sudden deaths are due to tox-positive drug. It may not be aware of it, or the family may not be aware of it. So always, in every case, we will do drug testing. Once we eliminate the non-cardiac causes, then we look at the cardiac. And the role of the pathologist is to establish, is the heart normal? Is it morphologically normal? If it is, then we think of SAD, sudden adult or arrhythmic death. Also, we decide, is the heart abnormal? Is there particularly entities like a cardiomyopathy or a normal coronary artery? Is there myocarditis, etc.? That's our major role. Is the heart normal? Is it abnormal? Now, this is our database results from the last, you could say, 20 years of my work. And what we have found is over half our cases, these are in young people mainly, 53% SADS, SAD, sudden arrhythmic death. The heart, green here, is morphologically normal. People die with absolutely normal hearts. So therefore, the channelopathies, the electrical abnormalities, are the predominant entity that we find at autopsy in young sudden deaths. The second most common entity highlighted here in red are the cardiomyopathies, making up 22% of our cases. Then we've ischemic heart disease, coronary artery disease, because even in young people, 9% of our cases are due to ischemic heart disease. Then we have congenital heart disease, valve disease, aortic stenosis, and prolapsed mitral valve, myocarditis and sarcoidosis, hypertension, aortic dissection, making up 2%, peripheral vascular aneurysms, 1%, and conduction diseases like heart block and Wolff, Parkinson, White, making up a very small percentage, just 1%. Today, I will concentrate on SADS and cardiomyopathies. Why? Because these are genetic causes and the families will need screening. And you can see here that the majority of all these cases are male predominant. Males predominate over females in all these entities: SADS, ischemic heart disease, hypertrophy, arrhythmogenic cardiomyopathy, hypertrophic, dilated cardiomyopathy, even in congenital heart disease. So males are more at risk of sudden death than females. When we look at age, the younger patients are more likely to have SADS, channelopathies. The older age group are more likely to have cardiomyopathies. Also, older age are more likely to have ischemic heart disease, valve disease, and hypertensive heart disease, whereas congenital heart diseases are more likely in younger patients. So age is important. And younger people are more likely, these are under the age of 16, to have SADS and cardiomyopathies. Here again, the under 35s, the older 35s, younger SADS, older cardiomyopathies. And again, in the younger age group, you can see SADS predominate and cardiomyopathies. So cardiomyopathies, SADS predominate in all age groups. So what's the importance of SADS? It is sudden arrhythmic death. The heart is absolutely normal. We pathologists say we cannot find anything at autopsy. It's called a negative autopsy. So then the utility of post-mortem genetic testing is vital. And we have published on this with our colleagues in Holland and in Denmark and in the United States and in Australia, where we have found that genetic testing is important. The first genetic test yielding a result was in the early 90s, done by an Ackerman in the USA. So molecular autopsy, it's called, provides diagnosis and identifies relatives at risk if you find a positive mutation. You require DNA and a suitable tissue for DNA extraction. Family screening in sudden and unexplained death, these are the entities: long QT syndrome, Brugada, CPVT. But interesting, we also find mutations in cardiomyopathies, arrhythmogenic, dilated, and hypertrophic. And the yield can vary from 0% to 30 to 40%. It's quite variable. But with increasing panels that are being used and a larger actual panel of genes, we're getting more positive results. So now in the 2020 guidelines, expert consensus statement, genetic testing is becoming more and more important. And why? Because we're doing testing for Brugada, long QT, CPVT, for conduction defects, but we're also including hypertrophic, arrhythmogenic, and dilated cardiomyopathy in the panel of genes. Why? Because also with the normal, we have hypertrophic, where you have a thick heart, a dilated heart and dilated cardiomyopathy, and in arrhythmogenic, we have a fatty heart, right? We also have restrictive cardiomyopathy and endomyocardial fibrosis. These are the diagnostic criteria for each of these entities. I will not go into detail about them, but what cardiomyopathies do we see as pathologists? Well, we see, interestingly, idiopathic hypertrophy. This is where I see a heavy heart, well above the normal weight heart, but the person does not have hypertension, does not have hypertrophic cardiomyopathy, does not have aortic stenosis. The next most common cause is hypertrophic cardiomyopathy, here highlighted in red at 19%. Arrhythmogenic in purple makes up 18% of our cases. Dilated makes up 16%, but we also have OCM, which we call obesity-related cardiomyopathy, where you have a heavy heart and a person who's obese, and that is becoming a more increasing entity. And what you get is hypertrophy. There's an increase in heart weight, and the thickness of the muscle in the left ventricle is increased, and the weight is increased above 500 grams in male and above 400 grams in females. This is a case of hypertrophic cardiomyopathy with a very small chamber, hypertrophy of the trabeculae and the papillary muscles, and increase in thickness of the wall of the septum and the free wall of the left ventricle. And now, sudden death can be the first manifestation of hypertrophic cardiomyopathy. The family may be totally unaware they have it. Here is David Frost, a well-known, particularly among the older members. He was a famous broadcaster, and that's his young son. His young son died suddenly while out exercising. His father had had an autopsy. The father had a heavy heart, but no histology was taken, and the son had hypertrophic, and retrospectively, his father had hypertrophic cardiomyopathy, but it was failed to be detected at the father's autopsy. If it had been detected in the father, perhaps measures could have been taken to prevent the death in his son. So 78% in our series of hypertrophic cardiomyopathy were first diagnosed at autopsy. So the autopsy is vital in making the diagnosis. Right? Etiology of sudden death in sports, hypertrophic cardiomyopathy is very important with myocyte disarray, but also idiopathic hypertrophy, where there is no disarray, but the myocytes are hypertrophied. Where at the moment, remember, there are mimics of hypertrophic cardiomyopathy, which I tell pathologists: hypertension, renal disease, aortic stenosis, obesity, athletic remodeling. Elite athletes have heavy hearts. But also you can have phenocopies like amyloid, Anderson-Fabry disease, steroids can have you an enlarged heart, drugs, neuromuscular diseases can make your heart heavy. So these are entities pathologists have to differentiate from hypertrophic cardiomyopathy. Here's an example of Hunter's disease with a hypertrophy of the heart and apical aneurysm. Here's an example of Fabry's disease with hypertrophy and vacuolated disorganized myocytes. In children, you can get hypertrophy as well. So look out for in pediatric cases where you get massive hypertrophy, but look for metabolic disease as well as hypertrophic cardiomyopathy. Idiopathic left ventricular hypertrophy. What does that mean? Where we do not have HOCM. Well, in these cases, we have looked at the diagnostic yield of hypertrophic genes, and we don't find hypertrophic cardiomyopathy genes. We find Brugada genes, we find long QT genes, we find WPW, we find dilated and arrhythmogenic, but we don't find hypertrophic cardiomyopathy genes. So it doesn't seem to be related to hypertrophic cardiomyopathy. Now going on to the other, we've dealt with hypertrophic, we've dealt with idiopathic. Dilated cardiomyopathy, well, that's where you have a dilated, thin-walled left ventricle, and you get fibrosis in the ventricle, scarring, here highlighted in red with picroserious red. That is a very, 16% of our cases are dilated. You have to look for alcohol, toxic causes, drug causes, chemotherapy, but 40% are genetic, so the family will need screening. Now, arrhythmogenic cardiomyopathy. This is an inherited genetic disease in the majority of cases where you have fat infiltrating and replacing the right ventricle, but you also get fat in the left ventricle. We now know it's a biventricular disease with fat in both the left and the right ventricle, particularly infiltrating from the epicardial surface. And you get sudden death with left ventricular involvement. Histology shows fibrous tissue as well as fat replacing the myocardium. Very important, differentiated from fatty infiltration, which is common in obesity. In obesity, you just simply get fat with no fibrosis. So again, reiterating the cardiac causes of sudden death, SADs and cardiomyopathies. And idiopathic fibrosis, that's where there's scarring in the heart, and there is replacement by collagen, but we do not have a dilated heart or a hypertrophied heart, a normal heart weight. We simply have scarring. We simply don't know the cause of this. We are now looking at genetic analysis of these cases to see, are they genetic or are they acquired toxic? So in arrhythmogenic cardiomyopathy, DCM and HCM, we have genetic mutations. And I think going into the future, we will do genetic profiling of sudden death victims and their families, so that appropriate therapy can be instituted for all these conditions in the future. Obesity cardiomyopathy is where you've increased thickness, weight, and fat in the left and the right ventricle, and it's increasing in incidence. So remember, all these are genetic causes. Vitally important to do genetic testing, do an autopsy, do the family screening. Family genetics are important. The role of the pathologist is to delineate clearly the phenotype at autopsy, correlate with the cardiologist with family follow-up, correlate with the genetic testing, so we have a multidisciplinary approach to the individual sudden traumatic cardiac death for a family. Here are our criteria we do pathologically, which I've published on recently, and now within the United Kingdom we have a national genetic testing directory for sudden death. We've got areas throughout England that we now are carrying out screening of families throughout north, south, east and west. We're expecting 3 to 4 cases per month in each region, and we have the role of the pathologist is vital to carry out the autopsy. Here are the inclusion criteria: mitral valve and left ventricular features. In malignant mitral valve prolapse is an entity where you have prolapse in the mitral valve, and scarring. We're seeing more and more of that as a valvular cause of sudden death. And going forward, the program objectives involving pathology, here the coroner, the NHS, Genomics England, and I think this is what is to happen. Money needs to go into this, and I think we can have a discussion within your own country as to the role of pathologists, cardiologists, genetic screening, So that as an overall, from the autopsy room, examining the heart, doing histology, doing genetic testing, and involving pathologists, training them, and cardiologists like Sanjay Sharma, Elijah Bayer, Michael Papadakis, whom I work closely with at St. George's. Thank you very much. And with that, I will hand you back with the last slide saying histology and examination of the heart is vital in determining the cause of sudden death. Also, in addition, we're getting an increase in survival with resuscitation. So training in resuscitation and in the use of defibrillators publicly may decrease, but tragically, the majority of people die at home or in the community. But the message is we are improving the survival rates with the use of mobile defibrillators and training of the community to actually carry out CPR. Thank you very much. Thank you.
Thank you so much, Professor Shepherd, for that enlightening talk and fantastic talk as always, and giving us such a wide variety of opportunities to learn about how we should assess the heart and what we need to see, how the future needs to be designed to prevent sudden cardiac death, especially in a country like India, where again, I think there's still a need for things to be developed. With that, I would like to invite our first chairperson, Dr. Praveen Chandra, to say a few words about the presentation and see where does cardiac pathology future lies in India and what needs to be done. Dr. Chandra.
Yeah. So thank you, Dr. Rajay, and it is a pleasure to be here on this platform today to hear this extremely, interesting, educative presentation by Dr. Mary. And she has really, I will say it was an eye-opening presentation for us. And as a cardiologist, it gives us so much information, so much insight as to what can be done and what should be done. So this is really, really very, very educative for all of us here, and learning that the causes of sudden cardiac death in different age groups, and that amount of data which she has shown. I have never seen this. For me, this is like first time, I must say. So very, very interesting. And I would like to know a few things, because you have this information now with so many autopsies and so much of genetic testing. So Professor Mary, can you tell us what are the doables which you have done in your country after seeing all this data? What steps have been taken? Because if we embark on this kind of journey in India and think that we want to do this and we try to organize everything, certainly I also have to tell people that this is what we are going to expect. What will be the outcome of this kind of information or study, and what has been done already in UK, and you can tell us, enlighten us as to what did you do after this to improve the outcomes, and what we can do to convince people to do this.
I think, thank you. That's a very profound question. What we've done, as I said, we've started up a national program in 7 areas of the United Kingdom where all sudden deaths go down a pathway, and they're all done by a pathologist. The heart is examined, genetic material is taken, and then once a genetic cause is established by the pathologist, the family is then put on a pathway to go to designated inherited cardiac centers. This is where cardiologists who are experts in channelopathies and cardiomyopathies and in the risk stratification of sudden death will see the family. In other words, the family need to see specialists, and they need to be seen rapidly within hopefully 6 months of the death. So we're speeding up this pathway and smoothing it for each individual region. And each region is going to be designated and funded by the NHS. In addition, the pathology will be funded by the NHS. You're absolutely right. It's going to cost money. And we will have to see, we're doing a cost analysis so that within 5 years, we see how many lives have been saved, how many families have been screened, and what the results are. But it'll take 5 years, and it will take money within the NHS. But lucky enough, that money has been assigned to do the genetic testing. and to do the cardiological screening of the families. So hopefully we will give you an answer within 5 years.
Thank you.
Thank you. Thank you, Prof. Thank you, Dr. Chandra. With that, I would like to also invite Dr. Pramod Kumar, Head of Cardiology at Medanta Patna. Dr. Kumar, we have been talking about it, especially now in media. There have been some cases reported of some known individuals who have died suddenly during exercise, during singing. There was a very famous singer who died suddenly. But again, we still don't know what caused the death in these individuals, because again, we don't do a proper postmortem to identify the cause for sudden cardiac death, sudden cardiac arrest, or SADS death, whatever the death may be. So what is there that we need to do in India from the cardiologist side of things, from the cardiological society side of things, from institutions like Medanta side of things, to make a start or to convince the government that something like St. George's, even a start has to happen in India to start diagnosing, to start running clinics in India. For example, at St. George's, we run about 6 inherited heart disease clinic on a weekly basis. There are 6 inherited heart disease consultants who are seeing these patients and families left, right, and center. We don't have a database to say how many of these people are dying from SADS or sudden cardiac death or inherited heart diseases. So where should we start, Dr. Kumar? You're on mute, I think, Dr. Kumar.
Thank you, Dr. Rajay. First of all, many, many thanks to Dr. Mary Shepherd for such an inspiring, talk. It's an eye-opener for all of us, like what Praveen said. And we are right now at ground zero. We have absolutely no idea what's happening. So we have to start from the scratch. We have to start building our database. We have to locate these people, and we have to travel the same path which you people are doing. But it's an enormous task for India. Unfortunately, Cardiological Society of India is not really into data collection and real, genuine research. So that's a very big tragedy for us. But, we have to make a beginning, like what Praveen said, that it's an eye opener. For the first time, we are listening to this kind of data, and which is possible. It's possible even in this country. But, the institutions in India, even the teaching institutions, have almost stopped doing autopsies. PGI Chandigarh was one place where almost every death, underwent autopsy, but that has almost stopped. So there has to be a beginning. People think that, like what Dr. Mary said, they feel that MRI is what it needs to be done for everybody, and that will give you all the answers. So histology has taken a back seat. So I think we need to restart all these programs. We have to convince the government that it's not only the young people who die suddenly need to have an autopsy. Almost 50-60% of the people who have unexplained death should undergo autopsy, so that we can have data, and then we can, follow the path which you people are taking. Very inspiring talk and real eye opener for all of us. Thank you very much for doing this.
Thank you. Thank you, Dr. Kumar. I would also like to take some expert comments from Dr. Nakul Sinha, because again, Dr. Sinha, there has been a lot of discussion, especially post-COVID, that are we seeing rise of sudden cardiac death in India because there is some scarring happening on the heart muscle leading to heart rhythm disturbances post-COVID that is responsible for some of these sudden cardiac deaths? Or is it just that we are reporting more deaths recently because many of the individuals who have died suddenly are very famous individuals and it makes headlines and news, and that is why there's more awareness? So what is the real scenario when it comes to sudden death in your part of the country?
First of all, let me congratulate Dr. Shepherd for invoking in us a real admiration for cardiac pathology. During my stint in Commonwealth Fellowship in UK, that was more than 30 years back, we had a sort of brush-in, but that was just a teaser. We never really got to know the intricacies of that. So, Raja, you have raised a very important question. The problem is that in COVID, everything and anything was blamed on COVID. And there was a peculiar situation here that the government was not ready to sort of accept that. So on one hand, everybody was suspecting that this is a COVID death, and then no autopsies, but then the data was being brought out. No, this was due to something else, this and that. Even the supposed reactions to the COVID vaccine had a lot of controversy. And ultimately, as we say, unless we let the scientists work independently, there's not going to be any meaningful answer. But yes, COVID really was a disruptor, and things were happening so suddenly, so sort of monstrously, that people were not ready to really understand what was going on. But yes, one thing we saw during those days, for perhaps 1.5 years, that there were suddenly a lot more arrhythmias, a lot more MIs in younger people. And on angiogram also, we had sort of soft plaques on imaging, left main disease, severe LV dysfunction. But many of them could recover, mostly with proper revascularization. But even without that, we could see a lot of recovery. So one thing I would like to ask you, Dr. Shepherd, is we know there are certain platforms where the patients or populations are predisposed to sudden cardiac death. Do you think that COVID or other stressors are needed, or mostly these deaths will occur even without the stressors? Now, stressors can be physical, as we see in very intense physical contact games like soccer, or the World Cup is going on.
Yeah.
We see the intense emotions, and we know that people die while watching the cricket or soccer, both sort of very popular in England and India both. So what would be your take on the role of stressors, that they are absolutely important or they may or may not be working?
That's thank you very much. That's a very interesting question. Stress, as you know, there's an entity called stress cardiomyopathy. You know, Takotsubo, where people get ballooning of the left ventricle, and it's transient and they recover from it, but some people die. But stressors for sudden cardiac death, like the channelopathies, yes, it's well known with long QT syndrome and Brugada syndrome that you have stress precipitating the arrhythmic event. And exercise in the fact of athletes, how many were elite athletes? In our population of 7,000, about 400 were athletes. So the majority are not athletes. They're not exercising. The majority of people die at rest. But stress or what precipitates it, we don't get those, like say if they have an argument or they've had a sudden bad news. We may lack that information, but we haven't noted the majority being due to an adverse event. But COVID is a very good question. We have not seen an increase in sudden cardiac death over the last 2 years. I'm still seeing the same number of hearts coming to me. So I'm not seeing an increase in sudden death. And I'm also not seeing an increase in myocarditis due to COVID as well. I've seen no myocarditis linked to COVID, fatal case. Although you are absolutely right, there is cardiac dysfunction in COVID patients, and they do recover, the majority, with or without coronary artery disease. So COVID has not been a stressor from my experience, whatever about other countries.
Thank you so much, Prof. I think, and thank you so much, Dr. Sinha, for raising that very important question. And I think maybe in the coming months or years, as there has been some discussion that whether COVID was responsible for some of these deaths with myocarditis happening or heart muscle problems happening in these people. So maybe in the coming months and years, we'll have some more answers from Prof. Shepherd and team. Maybe Dr. Ajay Sinha, if you want to bring in your comments, expert comments, please, for the session. Dr. Sinha, you're on mute, I think.
First, let me say that it is very enlightening. And I was going through the madam's work in past. Phenomenal kind of work, you know, every year they get about 500 cases of sudden cardiac death, and she has got a huge biobank. I mean, there can be a lot of information from that. And we in India, we hardly have any data. So my feeling is that can we start a database or registry of sudden cardiac death? Because this will give us, this will be the beginning of our journey, which C has alluded to. So let's begin with that. And one thing I wanted to say that if you see Bombay Municipal Corporation data of 6 months, you know, they have shown that the data of acute coronary syndrome, they rose from 5,000-6,000 to 17,000 in first 6 months. So I don't know. This is what we felt, and Bombay people gave up in a kind of publication and their thoughts also, that definitely the number of myocardial infarction in Bombay, in that area of Bombay Municipal Corporation, definitely is increased during last, you know, till the COVID year. So this is one. Secondly, how can we simplify? What can be, I have to ask ma'am, what can be the simplified version of, you know, how to go about in India about detecting those patients, those people who are going to have sudden cardiac death? Yeah.
Well, that's a very good question, because they're talking about population screening with ECG. But that is an enormous undertaking, and there's big controversy over whether it would be financially viable, because you'd need an awful lot of cardiologists to interpret the ECGs and also the echo. You need a lot of technicians to carry out the echoes. Let's say, like in Italy, as you know, they screen all young people entering secondary school who do sports. And they have found in Italy that the sudden death rate has gone down, particularly with hypertrophic cardiomyopathy. Although, Raji, I haven't seen recent figures from, I think there's also figures from Israel as well as Italy, but no other figures about screening and prevention, because it's an enormous amount of money if you're going to screen living patients. But what I'd start first of all is having a cardiac center for pathology, where if there's a case with an autopsy, the autopsy cardiac interpretation can be done. And I have colleagues in Mumbai, Professor Pradeep and his team work with cardiac pathology, and they do quite a lot of work, and they have a pathology group in Mumbai. Maybe can reach out to Bombay and other centers with pathologists and train pathologists who will look at these hearts appropriately. Start off small and gradually build up a database with both pathology information and the clinical information in the families. I think it's a major uphill battle, but start small and then develop it would be my advice, like we did. 20 years ago, there was nothing in the United Kingdom. Now we've established inherited centers. It requires money and a health service, and that is the biggest challenge in India.
Yeah. Absolutely, Prof. I think, as you rightly said, that we have to make a start, and maybe Dr. Sinha in Bihar and Dr. Nakul Sinha in UP can make that start to start screening young people just in ECG, because ECG can pick up almost more than 85-90% of these inherited heart conditions just by doing ECG screening. And that is what we do with the cardiac risk in the young. But also at the same time, I think that there's a need for cardiac pathologists to be trained. So all those deaths which are already happening, they need to have a proper postmortem, and a database should be there so that more of these deaths could be prevented. So I think maybe UP and Bihar will be a good place to make a start. And both of you, Dr. Sinhas, have got responsibility now to take this battle forward. Any quick questions from any of the other consultants in the because I would like to leave Prabha, because it's a Saturday. I don't want to keep her for long. So, and I'll try to bring in Dr. Shraddha Ranjan for vote of thanks. But before I do that, any other questions from any of the consultants?
Yes. One very important point, what I have got from Dr. Shepherd's presentation, that recently what we have seen, that the deaths in the youngs, especially it was in the celebrity group, that's why it was so much highlighted. But we have seen that deaths has been in gym, and deaths have been due to psychological stress. Even after the concerts, the person was sleeping at his home. We have also seen deaths in our cardiologists. So there are few things which have to be, which we need to be very vigilant of, because these some stress associated sudden cardiac death, there are very few differential diagnoses. The most important one is stress cardiomyopathy, which Dr. Shepherd said. Second is hypertrophic cardiomyopathy, those who are dying of sudden cardiac death in gym. Third is long QT syndrome, that is especially those are related to acute stress. And other one, the most important is CPVT. CPVT, it is also precipitated by stress. So in our part of India, at least we can screen for these 4 things in those families in which sudden cardiac death has occurred in the young age.
Yeah, absolutely. But I think, Dr. Shamsad, the bottom line is that a start has to happen to start doing autopsies, post-mortem on these patients who have died, so that we have or we don't have a diagnosis to say what has caused this death. So thank you so much for your comments. So with that, I would like to hand over to Dr. Shraddha Ranjan to give the vote of thanks to
Dr. Pavan, do you have any comments to make?
Thank you, sir. Actually, just I wanted to add one point that is in our country, people are not very keen to get the autopsy of the dead. That is a very demotivating factor. Actually, they are not keen to. What I have seen during the residency, that they don't want to get an autopsy at any cost. So apart from the finances and the infrastructure, this is also a very big issue.
I think it's you say a very important question, the negative attitude towards an autopsy. But I'll have to say, if my 17-year-old son collapsed and died, I'd want to know why. Wouldn't you? And that's, I suppose, it's older, elderly relatives, you would say no. And the sanctity of the body, etc., and religious and cultural reasons. But really, if you're talking about young people, a 17 and 18-year-old, which we get, then the family needs to be counseled to say, you have to have an autopsy because we think this is cardiac.
Yeah, absolutely. I think the awareness is very important. Awareness about
awareness in the community. I think
is very important because
yeah.
Absolutely. I mean, when we do our screening programs from cardiac risk in the young, we go to a village, we go to a city, we screen about 100, 150 young individuals between 14 and 35 in one day. One cardiologist, 2-3 ECG technicians, 1 echo technician. You just need a team of 3 to 4 people. But obviously, the cardiologist needs to be trained to pick up all those changes on the ECG, to pick up inherited heart conditions. And I think that can be a small start, as I said, to at least create awareness and take a business case to the government of India to say that this is very important, because this is also one of the things that needs to be addressed in coronary artery disease. Because again, the new pulse survey from the WHO says that non-communicable disease in the next 20 years is going to rise by up to 70%. And again, heart disease is one of them. So it is very, very important that we address this issue as well, which is unfortunately killing some of the young individuals in India. So thank you so much, everyone. And maybe over to Dr. Shraddha for your vote of thanks.
Thank you, sir. Thank you, sir. It's such an honor for me to deliver the vote of thanks in such a stimulating, wonderful session we had. First of all, I'd like to extend my thanks to our speaker, Professor Mary Shepherd, ma'am, who is undoubtedly the expert on sudden cardiac death. It was such a great lecture, ma'am. The research done by you has helped the whole world to understand what actually goes wrong when these young people meet this terrible fate of sudden cardiac death. So once we know what's going on, then we can predict, we can catch in the young patients who are still alive with our advanced imaging maybe, and with the knowledge of histopathology. Then, so that was very insightful lecture, ma'am. And as an imaging person, it was very, very, very interesting for me to listen to you. Then I would like to thank our own Dr. Rajan Narayan sir, who has made this session possible. So you are doing so much for betterment of healthcare India. And with your research, we as a nation lack in research, as we have already discussed. So you're doing so much, and we would like you to show us the way by these lectures and associations. Thank you, sir. Thanks a lot. And I'd like to thank our chairpersons, Dr. Nakul Sinha, sir. Your name is synonymous to cardiology in Uttar Pradesh. I belong to UP. So it's an honor to be there, and your comments were very, very insightful. And Dr. Ajay sir, you are leading this department with such an electrifying presence, and we are doing so much work. He has done so much work in sudden cardiac death training, CPR training, and everything. So you are the best person here to lead us, and maybe together we can work for the betterment of healthcare, and especially in northern part of India. Thank you, sir.
Thank you. Thank you so much, everyone, for joining. And hopefully we'll have some more sessions and exciting talks in the future. So thank you so much again. And thank you so much, Prof, for taking out time on a weekend. We really appreciate this.
Well, I'm going to Chandigarh, I think, to a congress in February, and I'm looking forward to it. Thank you.
Thank you, Prof. Thank you very much. Thank you, everyone.
Bye-bye.